This event that you're tuning into today is really all about building resilient health systems and using partnerships to get there. This is an event that Devex and AstraZeneca are bringing to you in partnership. We're really thinking about the role that the private sector, that government, and that international organizations play working together, and that a moment like this really highlights for us. So as I say, this is part of a broader UHC pavilion that we put on. If you've been following it, you know this already, but if not, you might want to go to our UN General Assembly website. That's unga75.devex.com. That's where you can find all of our journalism, all of the information related to the UN General Assembly this year, what was supposed to be a celebratory year, the 75th anniversary, and is obviously now very different. So that's where you can go if you get lost and you're looking for a place for more information. If you're tweeting along with us today, it's hashtag UHC Pavilion. You can look for us on social at Devex. You can use hashtags like UNGA75 and hashtag health systems. We are going to be joined today by an illustrator, Josh Knowles, who is going to help to take the conversation that we're all having and bring it to life in a visual way. That's always really interesting. We're doing that as part of the session today as well. And I've got a colleague joining me too, Rebecca Root, who's a reporter at Devex. Rebecca, maybe you can turn on your camera and say hi.
Hi, everyone. Yeah, good morning, good afternoon, depending on where you are in the world. I'm really excited to be joining this conversation. I'll be monitoring all the great questions that we have coming in. So if you do have one, just feel to put it in the little chat box at the side. We'll be monitoring those, and hopefully we can get in as many as possible throughout the course of the session.
That would be great. And I understand we have some poll questions that are up as well in Hopin, and Rebecca will be looking at those and following what you're saying on social. So she's going to make sure that all of your voices are integrated into the conversation that we're having. Nice to see you.
You too.
I want to begin with a special guest that we have. We are really honored to be joined by Dr. Leah Tadesse, who is the Minister of Health of Ethiopia. And to have a conversation with her, I'm joined by Aisling Mulvaney, who is the Global Head of Access to Healthcare at AstraZeneca and our partner in this event. Aisling, Her Excellency, Dr. Leah Tadesse, welcome to the conversation.
Thank you, Raj. Looking forward to this conversation. Dr. Leah, it's a pleasure to continue our discussions and our conversations.
Thank Minister, you very maybe much. I could just begin. Thank you. And maybe we just begin with you, Minister. I know everyone who's watching this is probably curious to understand the situation right now in Ethiopia as it pertains to the pandemic. We can just say a word about that, and then the connection between the coronavirus pandemic and the broader issue of health systems.
Thank you very much, Raj, and also would like to acknowledge and thank Devex and AstraZeneca for organizing this important event. As you said, I mean, the COVID pandemic in Ethiopia, although it started a bit late, we are on the rise of the number of cases we have every day, and also number of severe cases and deaths are also on the rise. Well, of course, since the beginning of the pandemic, there has been collective effort of the government in a multi-sectoral approach that we tried to quickly strategize and employ a whole of government approach led by the different sectors, of course, led by the highest level of the Prime Minister. And of course, this pandemic has challenged our health system, has challenged our world, but has also offered an opportunity for really a wide range of partnerships across the continuum of care, and to help us adequately respond to this crisis. And look,
maybe we could dig into that a little bit, Minister. Sorry to interrupt, but of course, you know, your countryman, Dr. Tedros, is probably the world's leading proponent of UHC, and he was Minister of Health. He had your role in the past, so he certainly knows well, and you and your ministry know well the importance of health systems. But as you were saying, specifically around partnerships, how has your thinking evolved there? What are you looking for in terms of using partnerships with the private sector, with international organizations to advance a more resilient health system in Ethiopia?
Well, in the broader sense of the health systems outside of COVID, I think in our efforts to achieve SDGs, especially our main focus being building a resilient health system and achieving UHC, it requires really strong partnerships and that harmonizes and aligns with our bigger strategy. And as government, we really try to follow the principles for effective development cooperation. And one of the key principles, of course, we look for is for all partners to support a single national health strategy and really have that coordination and collaboration approach through having a one plan, one report system principle that has been there for many years. And that really has helped the health sector and the government to avoid the fragmentation of support, avoiding parallel systems, helping a coordinated monitoring and reporting. And this has really, we believe it's really key to help the sector's efficiency for us to focus those, the available limited resources of the different partnerships, both by government and development partners, to build health systems. And we have seen it tangibly to help us expand access to services like construction of facilities, equipping them, improving training of health workers, and really focusing on the building blocks of the health system to achieve the MDG goals. So that has been really critical in terms of helping us. But still, aid fragmentation is still a challenge, which we really, I feel, we need to really work on to improve the impact.
Yeah, I was going to say, it sounds so logical and clear the way you describe it, that there should be one health system plan and strategy and everything should integrate. But of course, we know there's a long history of international organizations coming and doing something that's separate from the government, often with maybe good short-term intentions, but in the long run undermining the overall plan, or kind of siloed disease-specific approaches that don't take into account the broader health system. There's been enormous progress on this in Ethiopia and elsewhere, but you're right to bring it up as a key point. And I think it's a challenge as well for the private sector. And Ashley, maybe that's a way to bring you into the discussion, because you go around the world, including to Ethiopia and many other countries in the region, and think about how you can bring AstraZeneca's capabilities to help advance health goals. I know you have a particular initiative around heart health. And I wonder, from your perspective, how you see these partnerships evolving. What are the opportunities? What are the obstacles?
Thanks, Raj. And I echo the comments of Dr. Laya that currently there is a fragmented approach, not just in Ethiopia. And Dr. Tedros quite rightly mentioned just at the beginning of this month that there must be more investment in primary healthcare, and the pandemic has really highlighted where the gaps are and where there is a need to build back better, as we're hearing a lot, but also looking at healthcare resilience. And if we look even just at sub-Saharan Africa, we know they're going to have one of the largest increases in mortality due to NCDs. So even dealing with the here and now with the pandemic, we have to look at what's happening in the future. And where we come with AstraZeneca, and in particular the program you mentioned, Healthy Heart Africa, we're currently in 5 countries and continuing to expand, Ethiopia being one of our flagship programs, been there since 2016. It's really key to acknowledge that although there is different fragmented approaches, each country is different. And a one size does not fit all. And it's really important to work in partnership to understand the needs, listen to the goals and the strategy that the government want, engage with NGOs also on the ground to really do a tailor-made fit for the country. And what we do within Healthy Heart Africa is look at that sustainable healthcare approach. So we look at awareness and education, look at training and guidelines, and then also access and affordability to medicines. And they are all transferable skills. So once you get that framework set up, and the NGOs and the government and us as private sector start working together, there's joint learnings which then can be transferred to other disease areas and disease states. So we're looking at cardiovascular, in particular hypertension, but I have seen from other countries that the skills and the framework is transferred to respiratory or diabetes. And that's really important for that healthcare resilience and the long-term sustainable approach to healthcare.
Minister Tedesse, I wonder if there's anything you want to add to that in terms of how you look at the opportunity to partner with private sector and with not-for-profits, international organizations, the broad group. I mean, you have to have a plan of your own. As you say, it's a multi-sectoral plan. I think that's something a little unique in Ethiopia, that your health approach is quite multi-sectoral. Do you kind of hang up a sign that says open for business, we're looking for partners? Or do you come at this where you have a strategic lens by the sector, and you're saying who are the best partners we could access? Are you just waiting for people to come to you? How do you think about how a ministry like yours can approach this strategically?
Thank you. I do agree with what Ashling said, that we may not have just one approach for the partnerships. And one thing that really this pandemic has also taught us is really the wide range of partnership, even with private sector. For example, one area was really working with the manufacturing sector so that they can repurpose towards PPE production locally to mitigate the global crisis of shortage we had, while other private sectors where we really needed them to start managing COVID-19 cases or testing. And also with our development partners, there was reprogramming an emergency fund availing, with some were providing us with supplies and equipment, and of course integrating the work that we're doing with existing machinery like the community health work program, and having that being supported by both development partners and private sector. So what we had. So the approach would be we reaching out for both private sectors and development partners and civil society and communities for the areas we need, but also when people come or organizations come for specific areas of interest, and we try to align our plans, but also welcome that approach. So really it should have a wide range of really helping us build strong platforms of partnerships that can impact in many ways.
I wonder, for both of you, I have a question, which is, how do you think the pandemic is going to change the way you approach these partnerships? Because Healthy Heart Africa has been around before. There have been partnerships in the past. It does seem like the pandemic has shown us what's possible. I mean, we are the acronyms that everyone's using now are Gavi and CEPI, right? These global international public-private alliances. We have shortly going to be joining us the head of the Global Fund, Peter Sands, and the Global Fund is another international public-private partnership. It seems like the importance of public-private partnerships have grown in understanding and attention during the pandemic, and the level of urgency both private sector and government health ministries are bringing to this pandemic shows what's possible. So I wonder, for both of you, do you see things really shifting in the partnership space after and as a result of this pandemic? Maybe Ashling, if you want to begin.
Sure, thank you. So I think what it has done, Raj, to your point, is really shone a spotlight on the benefits of working together. And when there is a shared goal, we talk about public-private partnerships, and there is always a fourth P, patient, within that. And there was patients before pandemic, and there'll be patients after pandemic. And we all have a shared goal to ensure access to healthcare for all patients. And my thoughts are, with the pandemic, it's shown and it's built trust in the established partnerships that we have already. It's allowed more flexible and agile conversations. And it's also enabled to look at non-traditional actors in this space. Dr. Lai has mentioned manufacturing, how it's now transferred to develop PPE. There's been repurposing of budget. There's been changing of roles and responsibilities, but all with the shared goal of supporting access to healthcare for patients. Dr. Lai, any further comments from you?
Yeah, I completely agree. Yes, it does definitely will change how we partner for the better, I believe. And it has really helped us. For example, for health, when we look for partners, we usually look to very similar places. But this has helped us to really widen our horizon in terms of health diplomacy, working with different countries, with different organizations who may not necessarily have been supporting health before, but now it's everyone's stake. Everyone has a role to play in the supporting this health security issue. It has shown us how much everything is interconnected, and that every sectors need to consider health within their policies. So I hope it has widened the horizons and has shown different possibilities. And as health sector, I think we should build on what has been created through the opportunities that has been created through this pandemic in wider health diplomacy issues.
I imagine one example of that, of the new kinds of partners, might be around manufacturing for things like PPE that you mentioned earlier. Suddenly, ministries of health are thinking about, how do I quickly ramp up production, actual local manufacturing of goods, which may not have been something that was a priority in the past. I wonder if you think that the pandemic is going to change the priorities around the way we partner and the kinds of organizations we partner with. And just as an example, it seems like one of the most effective things the Ethiopian Ministry of Health has done against malaria and other infectious diseases in the past is data gathering, using, really understanding where the problems are. We're going to have someone from PEPFAR, the Deputy Global Ambassador for AIDS in the U.S. coming. This has been a big hallmark of their work, is focusing on data, understanding where the cases are, and using that to inform smarter approaches. Do you see new ways forward? You talk about new partners like technology companies, drone companies, other. Are we going to see a different group of people when you say health diplomacy is shifting, Minister?
Yes, absolutely. Data now, we need a real-time data every day now for our COVID response. It's not like what we used to collect maybe every month or so for other diseases. And this has also shown us the possibility of how we can really be more aggressive in the other priorities in health that we have. For example, within this response, to ensure the continuity of all essential health services, we've been trying to gather data of other infectious diseases and other prioritized NCDs as well, at least every week from all regions, to evaluate where we are while we are addressing the pandemic, to ensure that the continuity of services are happening. But this has shown us the need really to work better on having better quality of data and better timely data. And even when we are doing the surveillance for the COVID response, that has also helped us to really reach more population, but also gather more data and inform our decisions quickly, because this response has required us to have really an agile approach where we revisit our strategies at least every 2 weeks or so for the response, and that depends on the data that we have. So it's one area definitely, and the several areas you have mentioned. For example, the COVID response has shown us we cannot just respond for the country. It's all interconnected continentally. We have to look at it. So for PPE and other supplies, we have been using our Ethiopian airlines to ensure that not just Ethiopia, but all the countries are also getting supplies. So it has really opened up several kinds of partnerships, and we really need to look into building on that multi-sectoral and different areas of partnership.
And you mentioned health diplomacy. I can see that becoming a more important job title in the future based on what's happened during this pandemic, because so much of this does require having the right resources, connections, understanding the landscape, putting all of these puzzle pieces together, which is, I think, a lot of what you do every day, Ashling. Any take up from your perspective, Ashling, on this issue of how the multi-sectoral nature of this, the unique nature in some ways of this pandemic, things like using real-time data will change the nature of partnerships going forward? I'm reminded of the Ebola crisis in West Africa, and how the Gates Foundation found that a lot of their investments in polio led to having some infrastructure in place that helped governments like Nigeria to better combat Ebola. Will these things we're putting in place today against the pandemic give us an opportunity against the next pandemic or against other infectious diseases or issues like heart health that you're working on?
So I agree. Raj, and I agree with what Dr. Laya said. And when we look at, the mention of non-traditional actors, wherever there's a challenge, there is always an opportunity. And what we're all learning in this phase is actually going to allow us to come back better and stronger. It's opening up the dialogue. It's seeing different groups coming together that wouldn't have traditionally come together. And it will allow us to continue preparedness for a future pandemic, but also apply that thinking, as Dr. Laya has mentioned, just in doing the current healthcare now. So to Dr. Tedros's point, to actually now look to invest back in primary care, take the learnings from data gathering, from the surveillance. Is there something that we can get real time that's going to support that? I do think there will still be a need to go from grassroots up. There will still be a need to go for leaving no one behind and to continue to remember a patient. So let's not, throw the baby out with the bathwater. There's a ton of great work currently happening. There's a refocus and a sharper focus with the pandemic, but we do need to continue to work together and to look at that investment in health and to build resilient healthcare.
Yeah, when you think about the patient, so many patients around the world have not gone into their regular medical checkups, have not gone to the hospital when they have a problem because they're worried about getting COVID, or the hospital is closed, or it's COVID only. And we haven't yet seen all of the effects of that. But including in things like heart health, many experts are saying there's probably a lot of disease that's coming in the future that we'll see an uptick because people weren't able to do the prevention that they needed to do earlier due to this pandemic. So it makes you think about, what does resilience mean in a health system? Well, from a patient standpoint, it might mean being able to get access to their healthcare no matter what's happening. And that's certainly not easy in a pandemic like this, but you can see that it will have some big repercussions. Minister, we're running out of time, but I wanted to just give you a chance if there's anything further you want to tell us about your plans going forward. You're a relatively new minister in this role. When we think about Ethiopia's health system, what mark do you want to put on it in terms of making it more resilient, making it stronger? What are some of your priorities? Thinking of the international organizations that are listening to this, the partners that are listening to this, what message might you have for them?
Thank you. That's a tough question, but thank you. So as you rightly said, the key would be really, we have to learn from all the lessons and build on making our systems resilient, but focusing still on building a strong primary healthcare system. We have seen that in the first few months. Can you hear me? Sorry, seems my connection.
We hear you well.
Stable. Okay. Yeah, in the first months or so, we have seen the shift towards COVID response had impacted the services. We had all the other essential services, and we had to quickly react and respond to make sure that the continuity is there. But it is that a strong system where we can ensure wherever people are, we can continue those services, primary care services, while we respond to such pandemics, but also has taught us on how better to continuously build that multi-sectoral collaboration and respond to such pandemics. And so the key would be really to continue building on a strong primary healthcare system that also protects people from emergencies. So that would be the number one priority that we continue to build on, while we also work on ensuring that we have a local capacity for responding for such times of crisis in terms of availing commodities. And I do hope that also the support of partners on the way forward would be something to enable countries to have security, because most of the countries depend on other countries in terms of commodities and supplies, but we should use this opportunity to create local capacities in many countries, and that is something I also would like to continue build on based on what we have learned from this pandemic.
Well, you've given us many important themes that we're going to pick up now in our panel conversation. I know this is one of the most challenging moments for anyone sitting in your chair, so I just want to wish you very well in all the work that you're doing. And thank you for taking the time out to be part of this discussion. I know everyone is at home virtually applauding you. I wish you could hear that warm applause in person, but thank you again, Minister Laia Tedessi, for being a part of this today. As she departs us, I will ask Aisling to remain with us because you're gonna be a part of this panel, and I'll ask our panelists to turn on their cameras, and I'll just mention who they are and who's joining us as we continue the conversation. Siddharth Chatterjee is with us, the UN Resident Coordinator for Kenya. He is based in Nairobi. Angeli Achrekar, who's the Principal Deputy U.S. Global AIDS Coordinator at the U.S. President's Emergency Plan for AIDS Relief, better known as PEPFAR. And then Peter Sands is with us, the Executive Director of the Global Fund to Fight AIDS, Tuberculosis, and Malaria. All are people well known to the audience, the community following this. Their names you see frequently in our news coverage. And I'm really pleased to welcome them all to this conversation today. Maybe I can just begin by picking up on the discussion that we have just had. And we can just start with what you think COVID is doing to the partnership field, to the opportunity, to the way we're seeing these problems to begin with. And Peter, maybe I can start with you because these are not new things for you. You've been thinking for a long time and working for a long time on the disease areas you focus on, of how to make sure you're addressing those disease areas while strengthening health systems and bringing in relevant partners to do that. What has COVID changed, if anything, in the way you look at these problems and these issues?
COVID has been an extraordinary catalyst, actually, for more intense and more productive partnership. The Global Fund is, of course, a partnership in and of itself. It's a public-private partnership involving governments, civil society, technical partners, private sector. And what I think we've learned in the history of the fight against AIDS, TB, and malaria is that partnership is absolutely vital. We've also learned that partnership can be quite difficult because people have differing mandates, operating models, perceptions of the world, and it takes work to make that translate into concrete results. But actually, what we have seen in the heat of this crisis is actually some pretty extraordinary levels of collaboration. So in countries, for example, if I just take malaria, for example, we were first looking in February and March at seeing bednet campaigns, distribution campaigns being cancelled all over the African continent and elsewhere with malaria. Actually, virtually,
and the reason they're canceling because they thought people would be congregating, they would spread the virus, basically.
Exactly. They couldn't work out how to do it. How do you distribute millions of bed nets in the middle of a lockdown? The reality is none of those have been cancelled. Some of those have been a bit delayed. The actual operating model for the way they're done is differently. You're not delivering them to the middle of a village and having families all congregate to get them. They're being done on a door-to-door basis. And that speed of that response has required huge amounts of collaboration between national malaria programs, civil society, Presidential Malaria Initiative, the Global Fund, WHO, and so on, to work out what is the right answer and how to do it in this way. More generally, I'd say the ACT Accelerator, the Access to COVID Tools Accelerator, has seen certainly in my short history in global health, an unprecedented intensity of collaboration between global health organizations. So it has these three pillars around vaccines, therapeutics, and diagnostics, and then a horizontal across health systems. And again, I wouldn't pretend it's easy. We all come in with our own particular priorities, ways of doing things, and so on. But actually, as a model for accelerating the development and the deployment of these vital tools, I think it's working pretty well. So there's nothing like a crisis to get people to work together. I think it has done that. Could we do more? Absolutely, we could do more. There are large numbers of organizations still kind of sitting on the sidelines. But also the other thing is we need to make sure that when the sense of crisis passes, that we don't kind of revert to our old ways of doing things, that we take from what we've learned and continue to work with that degree of collaboration.
Yeah, and it seems like one reason why institutions like the Global Fund have been so successful is that they can organize around a very specific issue. They can be kind of fit for purpose. And the challenge with health systems is you really need to think about a much broader set of issues, and maybe you don't have the same political support for funding the broad health system as you might for a disease-specific area. You might not have the leadership in a particular government or ministry to try to drive forward a system-wide vision. This is something I think you at PEPFAR, Angeli, deal with all the time, because you've got a specific focus, but for a long time now, you've also said we're not just about this one disease area, we're about the health system. If we don't have a strong, resilient health system, we're not going to be successful. How do you see, just kind of the same, picking up off of where Peter left us, how do you see the pandemic shifting your work? Of course, Debbie Birx is now working on a much larger portfolio related to the pandemic, to the leading the global coronavirus task force in the US. But how has this affected your work at PEPFAR?
First, thanks very much. It's such a pleasure to be with all of you today. And I really just want to acknowledge such a timely session. So thank you, Devex. Thank you, AstraZeneca. And it's great, again, to be among you. Just as you say, I mean, I think, and just kind of reflecting a bit on what Peter just said as well, this COVID crisis has, yes, blown the curtain open on a number of critical challenges, disparities, et cetera, but it's also revealed what's possible, what we can do together with collaboration, building on existing infrastructure, the move, as we've been doing together urgently, quickly, not just to respond to HIV, but how we've been leveraging that platform for broader impact. So for example, in the PEPFAR world, I mean, again, we sort of, when we were tracking the data and really understanding what was going on with COVID-19 and learning from what was going on with COVID-19 around the globe, we immediately began to think about and issue guidance and move with, okay, what do we need to do a few key things? Number one, what do we need to do to sustain the gains that we've made in HIV? Number two, how do we need to work differently, adapt, be innovative to do that? And number three, how do we leverage this incredible infrastructure that has been established over 17 years of work in collaboration with country governments, with the Global Fund, with others all around the globe? There are 3,000 labs, for example, that exist on the continent of Africa. There are 28 reference laboratories. There are nearly 300,000 healthcare workers, community health workers, nurses, physicians, epidemiologists, et cetera, laboratorians that exist now because of this incredible work we've all been doing together. So we immediately shifted to say, okay, what do we need to do to both protect the clients that we're serving with for HIV, but then how do we leverage that incredible platform, that health infrastructure, to be helpful strategically, accelerate the work that we can do to respond to COVID-19. It is in our interest to ensure that those hard-fought gains that we've made are secured, and that COVID-19 is not then impacting these clients that are now on life-saving treatment. So there have been some silver linings that have come out of this COVID-19 crisis, some real critical innovations that, I'm happy to talk about later, but again, that we've learned and we're continuing to learn, that we're scaling and moving out quickly.
Yeah, I want to come back to some of that later on. I want to hear a little bit more about some of the partnership opportunities that you see coming out of this. But you're absolutely right that PEPFAR's legacy, the investments that have been made over time in this infrastructure, is now being used in many countries directly to deal with this pandemic. And perhaps to Peter's point about the ACT Accelerator, which is going to be an unprecedented ramp up of funding around vaccines and treatment and diagnostics for a specific issue for COVID, well, maybe that too can become infrastructure that we use in the future in other areas. So let's continue that discussion. I want to bring Sid into this now. because you have been a pioneer, Sid. I know, you've been on the Devex stage many times, and we've talked about partnerships you've helped to construct, bringing in the private sector, the public sector, wearing your hat at the UN. How do you think the pandemic has shifted our thinking on this idea of partnering to strengthen the health system?
Thank you, Raj. So let me start first by saying that without now a concerted push towards universal health coverage, particularly SDG 3, we are sitting ducks when the next pandemic strikes. And let's take that as a premise to begin with. So what COVID-19 has basically done is it's like the rain that exposes a leaking roof. The coronavirus crisis has revealed the unanticipated problems that are inherent in our dependence on global supply chains and amplified long-standing structural deficiencies in health systems around the world, regardless how developed or how least developed a nation state is. We can see that underinvestment in public health in one country is a threat to global health security everywhere. So responses to health emergencies cannot succeed if any part of the world is left behind. And this brings me back to the words of Herophilus, the famous Greek philosopher, who once said that when health is absent, wisdom cannot reveal itself, art cannot manifest, strength cannot fight, wealth becomes useless, intelligence cannot be applied. No government will win the victory on UHC. Governments have tried, and those governments that have been successful have perhaps been still reeling under the after effects of the COVID-19 shock. And therefore, this brings about why it is even more necessary, where the term too big to fail was considered, indestructible in terms of words. The largest companies have had to rely on, the Keynesian theory of having governments go out there and bail themselves, So I just feel that now is the time where we need to amplify public-private partnerships. In fact, in my view, public-private partnerships will be the new normal for the renaissance of multilateralism, where governments, the private sector, the UN, the public sector, all coming together and looking at this with a laser-sharp vision of this resurrection. Why am I speaking with such emphasis? In Kenya, we've made it work. We have had companies like GlaxoSmithKline, Safaricom, Huawei, Kenya Healthcare Federation, Merck, and Philips come together with the UN family, the government, and we were actually able to impact 6 of the highest burden counties and reduce maternal mortality ratios by 1/3. We've done it. And that is what led to Kenya embracing UHC as a principle back in 2017 at the World Economic Forum, where we got invited to showcase what's possible. In my view, this is absolutely doable. But there are certain things that we need to do purely from a public policy perspective. And these I will underline, particularly relevant to Africa, but this can be applied elsewhere. Keep in mind, we are going to see 2.3 billion people in this continent by 2050. Now, what we need to do is, first of all, reassess policy priorities and direct greater funding for health. So what the Minister of Health of Ethiopia said was spot on. We need to invest more on disease prevention. We need to improve the working condition of medical staff. In fact, I recently wrote an op-ed with the Minister of Health, and I said, health workers must have the same status as soldiers who've gone to battle and received gallantry awards. That is exactly the kind of recognition these people deserve. Offer fit-for-purpose health insurances to people. I mean, we are looking at 100 million people globally that are falling into deep poverty because of catastrophic out-of-pocket health shocks. 1 million in Kenya year on year. We need to harness big data technology and innovation to leapfrog universal health coverage. Recently, I did a trip to the Silicon Valley, and we are looking at an entire ecosystem there to come and work with us in Kenya to do precisely that kind of leapfrogging. What we will need is 2 more very important things, and Dr. Tedros talks about it. We need to create an army of community health workers which are tech savvy, connected to the internet. There will not be enough of doctors and nurses in Africa, for example, per capita population, which means more telemedicine, more reliance on technology to do that. And finally, the most important thing that will make this all work is robust public-private partnerships. In fact, that will have to be the new normal. So I'm delighted that we have AstraZeneca here, who we see as a very important partner of ours here with the UN system in Kenya in advancing the universal health coverage in Kenya. Over to you, Raj.
Thank you, Sid, for that. I mean, the description you gave of the leaky roof, I think, is really apt. And the cynics that we talk to, and there are lots in our field for good reason, will say, look, if you remember the Ebola crisis in West Africa, it wasn't until there were a few cases in rich countries that everybody started to get scared and do something big. And here with COVID, maybe it's a similar story where there's a lot of investment. There's huge numbers. I mean, the Devex tracker has now something close to $20 trillion or something in total commitments. But if you look at where that money is, it's almost all in the wealthiest countries in the world. And yes, Peter mentioned the ACT Accelerator, a tremendous opportunity for the whole world. But we still have a huge issue around things like vaccine nationalism around the pandemic. So, a cynic could easily say, look, this is just exposing the inequality in the health system, and we're actually going to have bigger problems as a result of this. Countries that have less budget for less domestic revenue will have less money to invest in health. The rich world is going to be less interested, they're more focused on themselves. How do we get out of this potential debacle that COVID could create? How do we construct kind of a bigger, bolder vision that has health systems at the center of it? I haven't yet heard a lot of big proposals out there from the likes of the World Bank or others to say, let's have a massive new global investment in health systems. Most of it does seem to still be focused on the pandemic itself. I wonder if Aisling or Peter or anyone would like to jump in on this, and how do we turn this huge challenge into an opportunity for health systems specifically, not just for potentially, disease interventions in the richest countries in the world.
I'm happy to go first and then hand over to you, Peter. So I think if we use the analogy of a leaking roof and what even Dr. Laya had mentioned previously, we know that we need to continue to focus on healthcare resilience, and the pandemic has shone a light on where there are gaping gaps. And what we don't want is to use the sticking plaster to fix a gaping wound. And we need to continue working together to look at the long-term resilience. We must invest in primary healthcare. And we've seen, and Sid has mentioned it, it's not just developing countries that are having issues with the pandemic, it's global. And we as a global nation, a global group, are only as strong as our weakest link. So it's really important that we work together, and by having a shared voice and a shared goal, we should be able to galvanize community to come together, to take the learnings from COVID, to take what's been working well so far, to take the great strides we've made in universal healthcare, to actually see how we can build back better. Peter.
I would differ with you on one thing, Raj, which is that I don't think we should think of health systems as being an end. Ultimately, I think the SDG 3 goal of health and well-being for all, which talks about people, is what we most want to focus on. Because the history suggests, and we look at the largest multilateral provider of grants for health systems, so we've got lots of bruises and scars of this, but history suggests that if you invest in health systems and you don't keep an eye on the outcome for people, you end up wasting money. And so ultimately what we need to be doing is looking at what it means to individuals, to families and communities. And absolutely, it's got to look beyond an individual disease, and to solve the problem, you have to build the systems. But your measure of success should never be, how many warehouses or how many labs or your measure of success should ultimately be, what's your child mortality rate? What's all the metrics that tell you whether you're actually making a difference to people's lives. And I think it's always been the trade-off between the disease-focused approach and the broader system approach, is that the disease-focused approach has the disadvantages of being more siloed and narrow, but it has the great advantage of having really clear focus on outcomes. And the system approaches have some advantages in looking at this broader picture and building systems, but have struggled often to really have that same sharp focus on outcomes. And I hope that COVID will be a catalyst to us sort of breaking that conundrum and saying, actually, what we need to be doing is building systems that deliver outcomes. And actually, when you look at countries like Ethiopia, that is what they've done. And it's actually what we in the Global Fund, what PEPFAR, I think, are focused on doing. I do think that COVID is going to challenge us, though, in a number of ways. One thing I hope it challenges is what I think is an unsustainable distinction between threats we label as being global health security threats, COVID's definitely one of those, and threats because they no longer threaten the lives of people in rich countries, are no longer given that label, but are thought of more in sort of humanitarian or global solidarity terms. And you know, the
tuberculosis, for example.
Tuberculosis, for example, or HIV was the last big pandemic to hit humanity. But once it stopped killing large numbers of people in the richer countries, it sort of fell off the global health security agenda. Now, I don't think that works. From a moral perspective, I don't think it works. I also don't think it works from a political perspective. I've been on calls like this where people are saying we have to persuade all the countries in the world to invest more in preparedness. Absolutely. But are you going to ask countries that have high burdens of diseases like HIV or TB or malaria to divert money from saving lives now to preparing for things that might kill them? I think that's a really, really difficult proposition. But also from a practical point of view, the things you do, and Angeli made this point really clearly, the infrastructure you put in place, the capabilities you put in place to fight an endemic disease are exactly the same capabilities and infrastructure you require when you're faced with a new threat. So it's not saying we should do it necessarily the same. I think we should, when we put in place labs for TB diagnosis or for viral load testing, we should now be thinking even more explicitly about how we make them multi-purpose. I think we should build in that kind of multifunctionality and protection against future threats more explicitly into the way we fight the existing threats. But the idea that these are two separate things and that we should approach them with kind of different agendas and different funding channels. Well, to start with, we've been trying to do that for the last decade or so, and it hasn't really worked. But second, I just don't think, you know, when you unpick what you actually do, and the last point I'd make is, in health systems, as in most things, the muscles that are used are the muscles that work. So if you are building labs and supply chains and community health worker systems and so on to fight existing diseases, surprise, surprise, when you've got a new one, these things actually function. If you're building them for theoretical threats, and we have had investment in kind of labs for things that might happen and so on, what you tend to find is when you try and turn the switch on and make them work, they don't function. So I do hope that we use this as an opportunity to think differently about that divide between fighting the existing diseases and protecting against the new threats, and find a way of making us more effective at doing both.
And that's a very compelling way to look at it. It makes me think about Sid's point earlier about wanting to one day envision a future where we have an army of community health workers who are tech enabled, who have all the tools they need. If we disconnect that from a specific immediate need that has real outcomes for patients, I see your point. We could end up with this army of community health workers that it really isn't being activated, isn't being used, isn't even ready when it's time. It has to be connected to a real need today that has outcomes for patients. Angeli, I see you nodding along as Peter made his case. What are your thoughts on this?
Yeah, no, I thank you again. I really, really firmly agree with what Peter just noted. And I think, you know, again, I feel like we risk so much by having this debate between, do we go vertical or do we go horizontal? I think, you know, staying focused on outcomes knowing that there is this kind of hypotenuse or whatever you want to call, I mean, there is this infrastructure that is in place that we know how to use, that needs to be in place that has been in place when H1N1 hit, when Ebola hit, when MERS, SARS, all of these, now COVID. I mean, it is that infrastructure that is being utilized. So I think, again, I want to caution us from moving away from focusing on the outcome. The outcome is ultimately about the clients, the people we're serving, and the impact that it's having on their health. And so again, I think we need to be strategic, deliberate, and intentional about how we utilize that infrastructure to best service the clients and the people that we serve. And I think just a great example, again, I really loved Siddharth's comments. And I feel like even just the case of community health workers, here's a very clear example of how that platform. So South Africa, for example, we've been working with the South African government, with the Global Fund for many, many years now on the HIV response. We support thousands of healthcare workers, including thousands of community health workers for the HIV response. Now, when COVID hit, we immediately moved together with the South African government to utilize those very community health workers that were in place for adherence activities for HIV to work on no-touch testing, for example, and thermometer checks, et cetera, related to COVID. Those very community health workers were upskilled in a way to focus not just on HIV treatment adherence, but also on COVID-19. And so again, I think there's this important way that we have to be thinking about what we're learning in COVID-19 and how we don't lose that, but build on that for the future.
And perhaps
Raj,
the thing that helps us
over there.
Yeah, go ahead, Sid. I was just going to say, perhaps that hypotenuse that Angeli drew for us with her hand, perhaps the partnerships are the key to that. That the thing that connects the patient outcomes to the system is in part bringing in these other actors that can create a more efficient and effective system. Go ahead, Sid.
It's just a historical perspective of something that really worked. In 1967, Lyndon Johnson decided that he needed to deal with the famine in India. So he sent a team to India to kind of look at what could be done. And the USAID administrator at that time coined the term called Green Revolution. And that Green Revolution actually brought US public-private partners, government, Indian civil society. And today, with a population of 1.3 billion, we don't have that kind of food insecurity and hunger that we witness in Africa. What we need is a health revolution. And that health revolution cannot be done by governments alone. We know that. Any of the most advanced, whether it's the most advanced governments and perhaps the weakest governments. This is where we need to also incentivize, and incentives matter. We know that. Where we can incentivize, I mean, let's look at Africa as a continent and its emerging demography of 2.3 billion people by 2050. By 2030, the expectation of healthcare business, and I'm now telling you projections, this is before the COVID pandemic struck, was about $300 to $400 billion. And that is what our UN SDG platform was trying to do, is how do we anchor Kenya as a best practice and establish a blueprint that will work throughout Africa? Because it's worked. It's worked in 6 of the high burden counties. The important thing is that we will need to bring the technology innovation and the big data that the UN, the government, and the private sector can bring to bear. I really believe the results that we can achieve through this sort of a partnership will be manifold. Don't forget, it was just 5 years ago, maybe 6 years ago, India finally eradicated polio. How did that happen? That happened because there was a community health worker that could actually go house to house. It was not the expectation of communities coming to a health facility because there are none, simply because of weak infrastructure. They were able to go, the Ashas, Angeli, if you'll recall, they went house to house to make sure that people got their oral polio vaccine and were kept immunized. As a result, a country of that size was able to defeat it recently. In my view, it's totally doable. Today, the kind of technology we have at our disposal, I mean, right now, as we speak, we have a midwife walking around in one of the largest informal settlements and it's on BBC, in Kibera. She's got a backpack. She's connected to the internet. She goes household to household to go and deliver babies, is able to deliver 7 or 8 babies. And at the same time, the woman does not actually have to trudge all the way to a health facility where she's not guaranteed care. This is not a traditional birth attendant. This is a trained midwife with all the equipment. And when she needs guidance, she's able to dial in. This is what we need to be doing. So we need to bring in the private sector to look at the opportunities of a return in investment. But it's clear what this pandemic has done is impoverished tourism. It's impoverished hotels. It's impoverished so many governments. And this probably is that wake-up call to resurrect and reimagine what the future of health will look like. And therefore, the primacy of SDG 3 is non-negotiable. Over to you.
That was fantastic, Sid. I want to come back to all of you in a moment, but I do want to mention to those who are following, we have a couple of poll questions on the platform. If you haven't had a chance to vote yet on those polls, please do. We're going to come to that information shortly. And I'm going to go shortly as well to my colleague, Rebecca Root, to see if she has any questions from all of you. So take a moment now to try to get those in. And I'll just see if Aisling or Angeli have anything they want to add to the conversation before we go to questions. Anything that comes to mind for you. Go ahead, Aisling.
Thanks. And I have to agree with all my panelists that, now is the time to take action. We've talked about it a lot in all our relevant sectors, but actually we are galvanized and can come together as a global community to actually address and to focus and to look at what we currently have learned so far. To Sid's point, community healthcare workers, looking at community volunteers, but actually how do we gain and maintain the trust in private sector, in PPPs, but also in the communities engaging back in the healthcare systems so that NCDs can be dealt with, so diabetes or respiratory can be dealt with. So those people who have HIV, they have the confidence to go back because we have set up the infrastructure and as a global community are investing in healthcare resilience to address the future pandemic, but also to address some primary care needs now.
Yes,
Rebecca Root, I want to welcome. Go ahead, Angeli. Go ahead.
I was just going to note just one piece related to the, I think, last point that Aisling was mentioning, and that is really, as we think about the absolute need for us to work together in public-private partnership in a new way, learning from what we are in COVID-19 and as we move into the future. Also, the role of our partnerships with communities. Communities are critical in so many ways. If we're going to get this right and really focus on a client-centered approach or really what matters to the people, we need community and we need them to hold ourselves, governments, accountable. So I think that I just don't want us to lose the role of community in all of this.
Yeah, that's a great point. And often when we think about partnership, we might go in one direction or another, global corporation, international organization, and actually it's a much broader concept than that. And maybe it does ultimately gets guided by this idea of patient outcomes. What's going to work best? I think about the DREAMS program, for example, at PEPFAR, and the need to involve people, involve communities at a ground level and the difference that can make. Rebecca, have we gotten any good questions in? And maybe you want to share the poll results for us as well?
Yeah, sure. Perfect timing, actually, because in our poll question, what is the key to a successful partnership? Most people actually agree with you, Angeli, and say consultation with local communities is the biggest key here. Strong government ownership and ensuring programs reach underserved populations were two of the other options, but consultation with local communities definitely came in at the top there at 63%. On our other question, how can the private sector best help advance UHC? Results were a little more mixed and balanced here. The options were by mobilizing private finance, by offering their expertise and know-how, and by ensuring sustainable market-driven models for health. That last option, that got the most votes, but generally results were quite mixed. So yeah, thank you everyone for sharing your views. Couple of questions, a lot about the idea of equity, about reaching the poorest, most hardest to reach populations, especially when you're thinking about a COVID vaccine and the role of health systems within that, but also how private partners like AstraZeneca think about health equity. So perhaps, Aisling, we can start with you on that one.
Thanks, Rebecca. I think now more than ever, it really does demonstrate the importance of health equity. Sid has said it's not just developing, but developed countries as well, and communities within those countries are seeing an impact of COVID, and it really has highlighted it. I think, with Dr. Laya and with Peter and all our panelists, we've all talked about the need for those open, transparent discussions, understanding the need and how working together can address and get to those more rural communities, if that's what's top of mind in some countries, but also looking at urban areas. And to really look to see if we are addressing it internally and externally to actually drive that need for health equity dependent on where the patient is, and to work together globally on that front.
Yeah, it's amazing how the situation has exposed those inequalities in our health systems, as Sid and you rightly point out, in both rich countries and poor ones. The access to medicine, the access to health, in a moment like this, it's very apparent where there are gaps, and there are huge gaps, no doubt about it. Does anyone else want to jump in on that point? Sid, perhaps?
So, I mean, it is perhaps now, a moment where perhaps the inflection point, maybe when we saw the rival to this during the Great Flu pandemic of 1918 to 1920, and the consequences of that. Perhaps now what it has done simply is that time there was this not exposure to knowledge and technology and innovations that were already around. I mean, this pandemic has given us the opportunity to really be fit for purpose in terms of our health systems thinking. And health system strengthening has to be, because we are talking about the entire ecosystem of health systems. It's not just, the doctors and nurses and the drugs. It is the preventative side. It is, the prevention of waterborne, vector-borne diseases. It is the prevention of jumping of zoonotic diseases. It's that entire ecosystem of prevention. And I think this has served as a wake-up call. In fact, as I said, this perhaps is that moment of the resurrection of the new multilateralism that we need to really advance the health systems ecosystem, because regardless of anything else, who would have thought that today the UK is actually thinking of a second lockdown simply because its systems are unable to cope with the fugitive nature and the unpredictable nature of this pandemic. And this means that what happens in the west of the world in one day can happen in the east in the other day, and vice versa. So perhaps now is that moment for us to rethink that new model. And to me, I just want to be abundantly clear. We need a multilateral system. We need a WHO. We need a PEPFAR. We need all of DFID. We need all the governments now uniting towards this one big endeavor, is to make sure that we are fit for purpose as a global community in terms of preventative health. Over to you.
We are getting close to the end of our time here. So I want to see, Rebecca, was there another question or point you wanted to raise now, or do you feel like we've heard it from the panelists so far?
Yeah, and there's one more question. This may or may not have been rhetorical, but it's, what else do we have to do to approach health challenges as challenges to humanities and not to societies? I know Peter touched upon that, but I wondered if he had anything to add to kind of make it a bit more tangible and action-oriented on that front.
Yeah, and I guess looking at the time, we're going to make this maybe our last intervention from each of you. So use this as an opportunity to share anything further that you would like to. I mean, Sid, as you point out, mask wearing, social distancing, these have been the main tools, lockdowns even. The main tools at this point in the pandemic aren't really traditional health tools. They're behavioral tools, they're social tools. And it's just shown us how interconnected all of this actually is, and how much it can affect and hobble even the wealthiest, richest economies in the world. Does anyone here want to comment on that question or add any final thoughts to the conversation here around how we can leverage partnerships to really advance and build more resilient health systems around the world? Go ahead, Ashley.
So for me, I would say access to healthcare is and should be seen as a basic human right. And if we have that and use that as our North Star as a global community, by coming together, we can tailor, we can tweak, we can work with different parts of the community and different sectors, but to really have patients and populations front of center of that, So if there is another pandemic, we're ready, but also looking at the current healthcare resilience and how we need to strengthen that across all aspects of healthcare to be ready to continue to deliver that access to healthcare for all.
And Angeli, a final thought from you?
I really, Aisling, echo your sentiments exactly. You took the words exactly from my mouth in terms of a human rights approach. I think that's the key. You know, health is a human right, and we have to take the approach of really prioritizing a human rights approach based on evidence, you know, based on science, and based on client-centered community design. So I think that's really it.
And Sid, a final thought from you?
Probably I'll rely on the famous adage by George Bernard Shaw when he said that no man is some men see things as they are and ask why, and some dream things that never was and ask why not. And we've come to that why not moment of why preventative health, universal health coverage cannot be achieved. And I think the discussion today actually is giving us perhaps that direction in which that we need to go to. But it is about scale, it is about depth, and it is about that we leave no one behind. Thank you.
Yeah, these words that we've used so many times before, like leave no one behind, take on so much new meaning right now. The idea that healthcare is a human right, as Aisling says, we've used this before, we've said this before, we believed it, but boy, in a moment like this, it really changes the way we think of those fundamental issues. I want to thank all of you. I know Peter had to leave a bit early, had to jump on something else, and I didn't get a chance to thank him, but I want to thank all of you. And I know everyone who's watching this around the world is virtually applauding you for a fantastic session, really inspiring remarks, and important remarks at a moment like this. So thank you for the work you're all doing every day. And thank you for being a part of this session.
Thank you.
Thanks very much. And as our panelists leave us, I'll give you some closing remarks before we welcome back our MC for the day. This has been an insightful conversation. It makes me think of some of the gaps that exist in the world, right? We began this pandemic with an idea that was out there that the pandemic would be a great equalizer because it was going to affect every country in the world, every person, every level of society. And instead we found it's just exposing all the inequalities that exist within our health systems, across our health systems. Many of the lowest income countries in the world spend $50, a few $100s per year per citizen. That's their total healthcare spend. The richest countries in the world spend several $1,000s and more per year. The gaps are enormous. This crisis means there's an economic crisis in a lot of the poorest countries. They don't have the tourism, as Sid mentioned. They don't have commodity exports to the degree they used to. And so they're going to have potentially less money to invest in that already very weak, very limited health budget. We're seeing new funds coming for things like the ACT Accelerator, as we talked about, but these gaps that exist are massive. And if we don't find ways to use partnerships, and that's why we thought at Devex this event in partnership with AstraZeneca was so important to bring to you today as part of the UHC Pavilion. If we don't find ways to use partnerships, we won't be able to fill these gaps. And the most successful institutions today, the ones that are at the top of mind for all of us, are these partnerships. Gavi, to make sure a vaccine gets delivered to every person on earth, no matter their economic standing. CEPI, making sure there's actual funds to develop vaccines, even for diseases that are neglected in the rich world. And the Global Fund, which is trying to ensure that diseases that affect most people, tuberculosis, HIV, TB, aren't forgotten as we attack COVID. So I think this was an important session. I learned a lot, and I want to thank AstraZeneca and all of you for being a part of it today. Hey, Vince, I see that you're back on screen. Nice to see you.
I was always here. And thanks for moderating. That was fun. I wondered what you made about Peter Sand's remarks about the need for the difficulties of fighting theoretical threats.
I think he's onto something.
What do you think about that?
Yeah, I think he's onto something because it's easy, especially sort of for technocrats, to say, hey, here's the perfect system I would like to build and map it out and draw it out. But in the end, these are political questions. And For many health systems around the world, a major source of funding is foreign aid. And governments have to build a political case for why they're going to send taxpayer money overseas. And that's a lot easier to do if it's around an issue like HIV, a disease area where people can understand the dramatic need to invest in it, the direct health consequences, lives at stake. So it makes some sense, actually, when you think about it, that if you think of the patient and you think of their needs and you're addressing it directly, maybe you can actually build something that is a stronger piece of infrastructure for the whole system than if you just try to map it out perfectly on a blank sheet of paper.
Yeah, I mean, I keep in mind, I was obviously at the Global Fund's replenishment in October for Devex, where Peter had a very strong alliance with Emmanuel Macron. And the French president invited the French journalist from the most watched television show in France to the Elysee the day before the replenishment. And he said, these are the diseases we're tackling. This is why. And the journalist obviously agreed to just ask about those things, because obviously there's a lot of things you might ask the French president one-on-one. But it was a really striking example of what happens when you get buy-in from the top level on concrete problems. And it was fascinating to watch the way Macron, instead of pitching it as, oh, foreign aid, he said, no, we're tackling, malaria, TB. And so
yeah, I think that's right. And as Siddharth Chatterjee talked about in the conversation, the opportunities that are big today are around innovation. And so maybe you're using data collection, maybe you're using, community health workers with smartphones, or as example of a midwife in Kibera, maybe you're using some tech around a specific disease area like HIV. But chances are that tech, that data is going to be very applicable across the health system. So if it really is about innovation, new technology, new ways of doing things, bringing in partners to do that, I think Peter makes a great point. You can do that on something that's very patient-centered and that does have applicability when you need it, when the next crisis comes up.
What about how children are faring in this pandemic? You spoke to the head of UNICEF recently.
And I think we're going to get to see that video in a moment.
Yeah. What was the flavor of your conversation there?
Well, it's sobering. I mean, you can imagine children are facing kind of an unprecedented situation where we've never seen this many millions and millions of children not in school at the same time. And if they don't have access to internet, again, the idea that this is a great equalizer is being shown not to be the case, right? If you don't have access to internet, distance learning becomes very challenging. Now, in many countries around the world, as we talk about in a bit in the conversation, they're using WhatsApp, or they're using radio, or they're using television. They're trying to find ways to deliver education, to deliver lessons to students in a non-traditional way. And it's great to see that innovation, but it's extremely hard. And home is not always a safe place for kids, and school is something of a refuge. So just that alone is a big impact on children. The virus itself may not be having as much of a direct health impact on some children, but certainly the education impact is massive. We talk about that. We talk about water, how access to safe and clean water has always been an issue for kids, but it's a bigger one now. If you can't get access to washing your hands, a bar of soap and a bucket of water